now we've got Dr. Gerry McCarthy, consultant in emergency medicine in CUH, and he's going to take us through the ED project update. Many thanks, Gerry. Now.
Hello, can you hear me okay? Yeah. Great. Thanks very much for the invitation to speak today to explain the implementation of ABF, the rollout into emergency department and injury units in Ireland. I'd particularly like to thank my friends in the HBO who have assembled in the front row to deal with any hard questions that I will do. I see my old classmate Michael Dockery in the audience. Yeah. As I figure out the
green button for next. There you go.
Okay, thank you. So I'm going to touch on what the essential task is that must be achieved in order for ABF to occur in emergency departments and injury units. I'm going to refer to the plan of how we're doing that, how we're getting on with that, and what the next steps are. So, there's the service. ED, injury units. It's a demand-led service, so patients can turn up and do turn up in increasing numbers without the need for an appointment. It's delivered on 29 sites around the country as emergency departments and 13 injury units. 11 of those emergency departments in and around the Greater Dublin area see only adults or only children. Everybody else sees patients of all ages. Injury units, the 13, have a lower age limit of 5, except for the 2 associated with adult-only EDs, which is 16. There's good reasons for that. Steady year-on-year increase no matter what we do, and importantly, the greater rates of increase are at the extremes of age, the elderly and the very young. Last year, almost 1.6 million people registered for attendance in ED. It's not that long ago that figure was 1 million. About 25% of the patients in ED are then referred for inpatient admission. However, there's a wide range, as you can see, from 10% of patients in the children-only EDs to up to 30% of patients in adult-only and mixed EDs, which is all ages. 20% of the patients turn up by ambulance, but again, a wide range from as low as 6% in the children's EDs. It's much easier to throw a child in the front of a car and bring them in a hurry, or what we call the white van syndrome, throw them in a van and bring them in, as opposed to waiting for an ambulance. And the level of anxiety associated with sick children is huge. So this is the basis of the system. Like all good HPO projects, we're using the Australian model, which is a very mature, well-worked-out model in Australia. The absolute essence, you've heard of DRGs this morning, the absolute essence of the emergency one is the assigning an urgency-related grouper, of which there are 114, to each and every ED attendance. What is an urgency-related grouper? To my feeble mind, it's a bunch of conditions with similarities, but it's not all the same diagnosis. For example, all patients with injury might be in a similar URG, but some of the variables used in assigning a URG on the bottom left of that slide there, the URG code comes from 5 pieces of data. We already have 4 of them in the PET data return. So the 4 on the left, episode end state, is what happened at the end of the patient's journey, where they discharged, referred for admission, given an appointment in a particular clinic. The type of visit, the vast majority are new people that we didn't know were coming. They developed an emergency and arrived. A smaller number, much smaller number, are unscheduled returns where they were discharged but they don't feel they're doing the way they expect to do, so they come back. And an even smaller number are scheduled returns where we say, I think I'd like to see you again in a week or 2, and we'll bring you back to a clinic. The triage category is important in terms of defining clinical urgency on arrival, how important it is to see that patient ahead of that patient. And it has been well shown in Australia to actually be an accurate predictor of the cost of treating that patient. Sex is used as an error checker. And then the Holy Grail, my whole mission in this that I'll explain to you, is to encourage my colleagues in emergency departments to assign an exit diagnosis code to each patient that they see. This is unique in ABF, where it is the clinician in the moment assigning the diagnosis. It's not done retrospectively. It takes about 25 to 30 seconds when you get good at it, but that is additional work for each patient that you see in an already busy environment. And bottom right there, you want to minimize the number of error URGs assigned to your patient workload, because there is a funding implication in that. So how does a URG get calculated? And I've stolen many of Emer's slides in this, and thank you for this one in particular, Emer. I don't do any of this stuff, but this is just to explain how a URG is assigned. All those Fs there in the middle of the slide on the right are particular diagnoses. They're all related to alcohol, drug abuse, alcohol, drug-induced mental disorders, and they all come into what's called a major diagnostic block. So you take the diagnosis and you then start to aggregate the diagnoses into a larger major diagnostic block. You also use, if you remember the 5 pieces of data we saw on the last slide, triage, sex is just an error checker, so really it's 4. The triage category is in there, so that's another factor in assigning the particular URG for this patient. And then there is the fact that they were not admitted. On the bottom left there, you can see that the exclusion criteria reflects the type of visit, in that it is a nonsense to think that somebody coming in intoxicated would be given a scheduled appointment for review. So, here's the project as we laid it out. First key thing we need to do is upload the ED shortlist. So the ED shortlist is out of the possible 20,000 diagnoses in the International Classification of Diseases. That's the ICD we saw on the last slide. Out of the 20,000 possible, there's 1,136 that are commonly used in emergency departments. So that's the ED shortlist. That's what you search when you're looking for the diagnosis. That's why it only takes 25 seconds as opposed to a minute if you were searching 20,000. Next step, and this is the bit that I've only appreciated as I've gone on, and it is actually important, which is to visit. I have one colleague in the audience. You know I have visited the emergency departments with colleagues from the Healthcare Pricing Office to explain the rationale for why we're doing this now, the many benefits available in having a diagnosis code outside of ABF, research, audit, planning, business planning, understanding your patient workload. We also demonstrate how to do it and confirm that it does only take 25, 30 seconds per patient. However, there are things in that I'll deal with later that can make it take longer. And then the phasing of the project in terms of, as my colleagues want, they want the data, they love the data when they get it, but then to analyse the data, understand the data, look at the implications of it, and then begin a period of shadow funding of ABF and try and minimise the amount of error URGs so that you're getting properly funded for your business. It has become apparent, and I kind of knew it was going to be, that there is a need for follow-up visits in some places and a bit of troubleshooting. And then finally, once we've had that first meeting where we meet the clinicians that we're asking to do this, and we meet other relevant staff such as finance managers, admin staff, clinical nurse managers that need to know this is going on. Once we've had that first meeting, they all have automatic access to a share file with a rich treasure trove of teaching materials, how-to and change management advice. So how are we doing with that project? We started middle of last September. Out of the 40 units involved in this, there is 1 left to visit, and that'll happen in the next week or 2. Half of the units, 20 out of 40, or you could say only half or already half, depends on what way you want to put it, are returning data. We'll see how much they're returning it in the next slide. The data flow means that it's included in the PET return to go to the Healthcare Pricing Office and then go on to the Business Information Unit. However, the range of compliance, so those percentages are the number of patients who attended the ED who had a diagnosis, an ICD-10 diagnosis code assigned, varies hugely, as you can see. I'll speak about barriers and enablers just before I finish. It is reassuring to see that there is a steady increase in the numbers of patients being coded over time. However, every so often it slips back, and when we inquire, we discover, the 3 people who actually were doing it have just gone to a conference or something like that. So trying to just get it to become business as usual is the real challenge that I'm sure we're all familiar with. Thankfully now, we've got to the stage with some EDs where we're getting enough data back that a report can be given back to them, explaining their compliance, explaining the spread of diagnosis, and that's really important. That's something we've never had in emergency departments before. We kind of know it, but when you get a query from the Department of Health or whatever, how many of this, that and the other do you have? You go, I'll give you a rough guess, but I don't really know. This is going to change all of that. So those reports are being issued. It gives the spread of diagnoses, it gives the spread of URGs, urgency-related groupers, and obviously the more hospitals that we're reporting, it gives us an idea of what the issues around the country and the emergency departments are, a much deeper understanding of that. So, barriers and enablers. guess what? IT is good and IT is bad. It is essential to have a functioning IT system. As I said, this is unique in that we're asking the clinician to do some extra work, to spend an extra 25 to 30 seconds. We've got to make it as easy as we can for them. They're the different IT systems in use. The vast majority are IPIMs. However, an awful lot of departments don't use IPIMs for any, the clinicians don't use IPIMs for any other reason. Symphony is in 8. All of the CHI units have Symphony, and all of them, except for Tala, are using the latest version of it, and therefore they're doing this for a couple of years. The other ones need to upgrade their version. 2 EHRs and 2 locally developed systems. Plans to upgrade or change IT systems is an important barrier stroke enabler in that it's very difficult to ask people, we know you're changing the system in 2 months' time, but can you do all this work, just upload the shortlist and get cracking on it in the meantime? Barriers to progress. Of course there's ED shop floor issues. We know it's a very busy place. It's a new requirement to interact with the IT system. The vast majority of people are okay with that. You know, they know it's not a huge thing. They can see the advantage of having the diagnosis code anyway. However, we've got to make it easy for them. There's never enough computers. And then you go and someone else has a different system open and you need the IP system, and it can occasionally take 3 minutes to log on. So we need to look at ways of making that still secure but as easy as possible so people will just do it in a heartbeat. App-based systems are available so they can do it on their phone, but that's another story. EDs are characterised by a very high rate of task interruption. I'm a consultant in emergency medicine for a long time, and I'll come out from a room having seen a patient, just finished with them, and there'll be 4 or 5 people waiting to discuss their patients with me, which of course you do. That's the nature of the job. You do it immediately. But it's really important that I remember I need to put in the diagnosis code on that patient. I need to go back and do it, the patient I was seeing. A last point there is an important point, and the exemplar of it is children who attend EDs. So if you remember early on in the slide, I said there are 3 children-only EDs in Ireland. Everyone else sees patients of all ages. 3 of the patients, EDs who see patients of all ages, see them by emergency medicine staff seeing them. All of the others, the triage nurse does a skilled assessment and makes a call on whether or not that child presenting has a medical type issue, such as respiratory or whatever problem, or a surgical, such as acute appendicitis or trauma, broken leg. The medical ones get seen in the emergency departments by and large by the inpatient paediatric team. A small few are seen in paediatric assessment units. The rest are seen by emergency medicine. The medical paediatric patients can be 12% of an ED census. So if we don't reach the paediatric staff and get them putting in an exit diagnosis code, you can tell me what the implication for funding for that is, but it can be a decent chunk of the service. So barriers to progress, data return issues. I know of places that are coding till they're blue in the face, but the data is not getting back into the PET data return. And it's been a surprising challenge to me to figure out who expands the PET data return in that hospital group or whatever, and how do we get it back. Once it goes back, it automatically, they love data. The more data they get, the better. But it's trying to make sure that it actually gets there. Another issue is that a lot of EDs, not a lot, about half a dozen EDs have been using some kind of local diagnosis code for years. So they're actually used to doing it, but it's not ICD-10, and that isn't going to work. So it's trying to get them to change over, get the shortlist uploaded and that. And some hospitals derive their PET data in different ways and are looking to send the diagnosis code directly to the HPO, which we're trying to avoid. Just as I finish up, 3 slides left, the future of emergency medicine, and these are things that I'm involved in and things that we need to figure out how to fund. Now, a lot of this is going on in Australia as well, so basically we ask the Australians, how do you do it? Age is coming in as a new data point because we know the numbers of people living with frailty and comorbidity is increasing, and it increases the cost of care. Community emergency medicine is the latest crack, where there are a number of different, Pathfinder, the APCAR in Cork, Edith in St. Vincent's, number of different versions of this where the ambulance service takes a call from a patient and says, I think if we send a clinician to that patient, we can avoid having to send an ambulance and avoid taking the patient to hospital, which is good. Urgent virtual care, I'm going to have to, I'd be delighted to talk about urgent virtual care, but I'm going to run out of time. But it is a means by which a GP or a paramedic with a patient who they think Their only option available to them at the moment is to send them to the emergency department. But if they can speak to an emergency physician, we're finding alternative pathways of care for about 70% of the patients that they ring about. They don't ring about every patient, so it's not 70% of patients. Next steps. When we started this in September, we wrote to all the REOs, but sure, things were really mad then in terms of the health authorities just being set up and that. I think things are a little bit more settled now, and we need to seek a meeting with them to try and get it on their agenda. Second last slide, I promise. Continue to meet staff to increase in compliance, identify barriers to achieving compliance, including access to computers and time it takes to log on. And last slide, compliance becomes a recurrent agenda item. So compliance with coding is on the relevant hospital committee's agenda, and they say we're doing well, we're doing poorly, or there's nothing to see here, move on. Timelines for necessary upgrades of some IT systems. It's really hard to push on that, but it's essential. And then, this has worked in one hospital with the highest level of coding, local reporting of compliance with coding. So, in other words, each clinician gets told, this is how many you're coding. What the HPO knows is how many overall are being coded, as opposed to who is and who is not coding them. Thank you for listening.
Brilliant. Okay.